Hi everyone, I'm Dr. Dean St. Mart. I'm one of the Trained by JP educators, and today we're going to discuss a little bit about PCT and how I believe PCT should proceed into the future. So what is PCT? PCT is post-cycle therapy. It's the phase that follows an anabolic cycle in which we are trying to get our HPTA axis functioning normally. The HPTA axis controls endogenous testosterone production. However, when we take exogenous testosterone or other anabolic hormones, that will shut down the HPTA. What that basically means is you are no longer naturally producing testosterone. So why do you need to do PCT? Well, without PCT, you are naturally relying on your HPTA re-signaling down to the testes to start producing testosterone again, naturally. PCT is a protocol which will help boost LH and FSH within the body in order to get testosterone production at an optimal faster rate. So why is modern PCT flawed? Well, first off, we need to consider what compounds we are taking, which a lot of people don't pay attention to. Within pharmacology, we have two distinct definitions which we need to consider, and they are one, pharmacokinetics, and two, pharmacodynamics. So pharmacokinetics deals with how the drug is absorbed, metabolized, excreted from the body. It's the rate order of how the drug operates. The second one then is pharmacodynamics, and that is how the drug interacts with the receptor or the target. So here we need to be paying attention to one, the pharmacokinetics. So the pharmacokinetics will give us an idea of how the drug is going to clear from the body. By understanding how the drug clears, we can then target a time when our endogenous hormones will be able to come back up again. That means making sure we land at close to a zero baseline hormonally. And that means being patient to allow the clearance of the exogenous drugs from your system. Now, today's PCT and all the bro science, silly protocols that are going around that generally state wait 2 weeks following a cycle is wrong. 100% wrong. Why is it wrong? Because 2 weeks after, say, even taking 150 milligrams of an enanthate ester, which some people do on a TRT basis, is still going to take up to 5 weeks to fully clear from the body. We look at the half-life of enanthate, for example, and that is 7 to 10 days. Minimum, we need to wait 5 weeks, 5 half-lives, for that drug concentration to hit close to zero, and that should bring hormone levels back to a zero baseline. What you need to be doing is 5 weeks after your cycle is draw blood, have a male hormone panel done and assess where testosterone, estrogen, LH luteinizing hormone and FSH follicle stimulating hormone lie. This will give you a brief idea of where you are falling now post-cycle. Most of the time LH and FSH are going to be suppressed and they're going to be close to zero. So ultimately this is where PCT comes in. Why the 2 week waiting period is flawed is because you still have exogenous testosterone within your body. That is going to prevent the HPTA from recovering, and it's going to stop LH and FSH from doing its job properly. Once we've ensured that the testosterone is cleared, that is going to give our body an opportunity to then react to the FSH and LH stimulation that we provide through PCT. So we've waited 5 weeks, we have our bloods done, we're sure that we're at a hormonal zero baseline, and this is where we then start to introduce gonadotropins, such as HCG, human chorionic gonadotropin, or HMG, which is human menopausal gonadotropin. What these do is basically mimic LH and FSH within the body. We are supplementing with an external source of LH and FSH to get our body producing endogenous testosterone again. So by supplementing with exogenous LH from HCG, it's going to boost intratesticular testosterone concentrations. So when we start HCG, the general literature is anywhere up to 2000 IUs 3 times a week, and it's been shown that this has been ran for at least 6 months. So no, you don't have to worry about any desensitization from LH. There is nothing in the literature to suggest this. This is where also the power PCT, not in a sense that it's flawed in that the compounds that are being selected are right, it's just the general advice being given out today in the time length in which you need to run gonadotropins. You need to keep running gonadotropins until intratesticular testosterone concentrations, which you will confirm via a blood test, are elevated to the point of a natural concentration, so somewhere around the region of 8.5 millimolar. That could take 2 weeks, it could take 4, or it could take 6. But you still need to keep taking HCG until endogenous levels rise to where they should fall naturally. Now don't misinterpret this. That testosterone concentration is being formed via exogenous LH stimulation. You're taking HCG, your body isn't producing its own LH. So now we've maintained a natural testosterone concentration. We can now look to get the pituitary involved, which is the main driver in the HPTA. So why does the HPTA get shut down? One of the mechanisms is high estrogen. And that is why when you start gonadotropins, you need to monitor your estrogen also. So that may involve needing to use an aromatase inhibitor like exemestane. That will keep intratesticular aromatization low. This will prevent estrogen from rising and prevent a further inhibition of the HPTA. So now that we have the gonadotropins, we have our aromatase inhibitor, we're keeping estrogen low, and we're waiting until endogenous testosterone has reached a normal concentration. Then we can look to get the pituitary involved, as I've said. Then we can look to stop the gonadotropins. Again, we need to do blood tests. That's the only way that you should be monitoring how your PCT is going to be successful. And then we can introduce a SERM, a selective estrogen receptor modulator, such as Clomid. Clomid's job is to act as an LH signaling boosting mimic. It binds with the pituitary and tells it to output more LH. So with more LH being produced, this is going to, again, it's going to boost intratesticular testosterone concentrations and get your HPTA back up functioning to where it should be before you even began your anabolic cycle. You need to keep running the SERM. The literature shows anywhere between 6 to 9 weeks, up to 6 months. You need to be careful though that you don't end up with overstimulation of the pituitary. Normally using a SERM for 6 to 9 weeks, wait 2 weeks and then get bloods done to assess where you are now naturally. So if you look back, we could be doing gonadotropin therapy for 6 weeks and that's followed with a SERM therapy of anywhere up to 6 to 9 weeks. So now we have a PCT length that's somewhere in around 12 weeks. This isn't spoken about today. I have no problem with guys, as I said, with the Power PCT protocol. It's how it's put forward and how you should be monitoring your recovery. I hope what I've covered in this video clears up any of the misconceptions that are towards timing towards PCT. And I'm going to leave below some of the scientific references which I've talked about throughout this informative video. I hope it clears up some of the questions regarding PCT and that you all have good recoveries. I'm tired of seeing failed PCTs. General thing which is often discussed on the Train by JP forum. People who have ran a PCT and 6 months later find that their endogenous levels are too low. Again, this all comes right back to the start. If they had been patient to begin their gonadotropin therapy when they knew that their endogenous levels were at a zero baseline. Thank you very much for listening, and I hope you take something away from this as I continue to help educate.